For those who do not know Dr. Sohaib, he is one of those very few people who has done double fellowship in anesthesia and critical care, as I've just mentioned. And he's one of those very learned people in Pakistan, among those very few. So the credit goes to him as well for his
Everyone,
work.
everyone here in Pakistan knows him very well. He's
Yeah.
the major person involved in every workshop.
Exactly. So that's why I said those who do not know him.
So now, Dr. Now it's all open. Uh, you can see.
Yeah. Wonderful.
Now it's okay.
Yes.
Fine. Okay. So this is the picture where this is a picture of the hospital where I work, and this is one of the called as a garden hospital here in Scotland. Uh, disclosure: This statement I disclose that I have no commercial or financial interest associated with this objective content or delivery of this session. So, what are the learning objectives of today's presentation? Is like we will just go shortly in a definition of what is surgical stress. Then I will define how, like, what are the neurological, endocrine, and metabolic response on surgical stress, and are there any methods to measurement of the surgical stress response intraoperatively, or like we cannot measure the surgical stress response? We will have one or two slides on that as well. Then, what are the effect of anesthesia and analgesia on surgical stress response? This is the main concern of as an anesthesiologist in a theater. We want to know that what will be the effect of anesthesia drugs like inhalational, intravenous anesthetic agents, and in analgesia, either like the opioids or like the other alpha 2 agonists which are in place right now have some effect on surgical stress response or not. And lastly, the post-operative cognitive dysfunction. If we do not mitigate this stress response, what will be the outcome on the post-operative cognitive dysfunction as well. So there are like a couple of definitions in the literature defining the surgical stress. So this is one of the definition which is like maybe defined as evoked physiological responses which trigger a hemostatic response to counteract acute physical or perceived threats during the perioperative, intraoperative, and postoperative period. This is the definition which was published in the Journal of Parenteral and Enteral Nutrition. So in 2013, there is another definition that is the human response to physical trauma, such as surgery, is a complex integration of events designed to heal injured tissue, prevent infection, and restore hemostasis. So in both of these definitions, the one thing is common that the body will respond to this surgical stress, uh, and the body will try to like restore its hemostatic nature, like want to blunt this response with their physiological changes in the body that can be at the level of nervous system, at the level of endocrine or metabolic, which will be discussed shortly in our coming slides as well. Interesting thing is that the current physiological understanding of this surgical stress response is derived largely from laboratory animal studies and healthy volunteers, rather than the surgical patients who are frequently older and have multiple comorbidities associated with established autonomic and endocrine dysregulation. So I will go through like a couple of things through my slides as well. Like the people who are older have a very blunt response this to surgical stress response due to their chronic hypothalamic pituitary axis activation. I will let you know what that is as well. And like patients who are already having a multiple comorbidities, like they have deconditioning heart with due to some heart failure or anything like that, they will also have a very bad surgical stress response in response to any major surgery, and that can affect their post-operative outcomes as well. Uh, how this surgical stress response came into literature towards the end of 1990s, interest grew in combining individual interventions and adopting a global approach to perioperative care aimed at producing stress-free anesthesia and surgery to improve post-operative recovery and reduce morbidity. So this was a main thing that came in like 1990s, and after that, the people started doing the things which were done individually for the patient. Now they started to done it as a like a routine protocols launched in the patients with a major colorectal surgeries or like thoracic surgeries, just to get this concept of ERAS, like enhanced recovery after surgery. And the main principal tenet was like stress-free anesthesia, which will help in healing the body as quickly as possible or keeping the body at the same physiology with which the patient came into the theater and going post operatively as well. So that will help in improving the outcomes of the patient. So always interested in what are the triggers of stress response. So there are like interoceptive stressors and exteroceptive stressors as well. What are the interoceptive stressors? Like the patient, if already having some infection, so he is already in stress, and we are giving him a surgical stress as well. Like with the surgery, putting the knife on the body and giving the pain and cutting the body tissues as well. He can have an inflammation, or he is already dehydrated, or the patient is already having some internal hemorrhage. So these are the endogenous stressors which the body is already going through. The others are exteroceptive stressors, which can be pain, anxiety, fear, something like that can be like from the outside of the body. And this slide shows what are the phases of these stress response. So there are three phases which are explained this general adaptation syndrome on this graph as well, which you can see. So there is like the one is the alert phase. Alert phase is always mediated by our nervous system. That is, we call it as a flight and fight mechanism as well. So there will be an intense release of catecholamine or adrenaline from the body just to mitigate the stress response. Then there is an adaptive phase. Adaptive phase is caused by this endocrine system with increased release of cortisol, ACTH, growth hormone, or antidiuretic hormone as well. So the first is the alert phase, and then there's the adaptive phase, and then the last is the exhaustion phase, which when we usually like in theater as well as in an ICU, we say that the patient has lost his all reserves as well. So exhaustion phase means there is a muted alert phase, and there is a continuous adaptive phase as well. So like alert phase is the first the mechanism which is neurologically mediated with increased catecholamines, sympathetic surge, causing tachycardia, tachypnea, and like adaptive phase in which there is cortisol, ACTH, and everything, and that will lead all the other physiological changes which I will discuss later in the slides as well. And the last is the exhaustion phase. So now we are coming to what are the physiological responses to surgical stress. So first of all, I will describe what is the nervous system response. So the first response, which we already said that it's an alert phase in which the nervous system is the main component which will get activated. So if there is there's a site of tissue damage, or like surgeon start the surgery, or there is like an injury or due to the trauma, or like the localized inflammation or pus going on. So there will be this is the efferent system which is going to the central nervous system, and this paraventricular nucleus is the most important part of the hypothalamus, in which all the efferent signals goes. And this paraventricular nucleus part of the hypothalamus, it usually have a direct connections with the anterior pituitary and the posterior pituitary gland, which will release different hormones, leading further the adaptive phase response of the surgical stress. So with this, there is with the nervous system, there will be the direct stimulation of the adrenal medulla from the hypothalamus, which will lead to the increased release of adrenaline, and which will lead to vascular smooth muscle contraction, increased systemic vascular resistance, which will lead to increased blood pressures and everything. That is the first response of this surgical stress, that is called, and the paraventricular nucleus along with hypothalamus. The paraventricular nucleus in the hypothalamus is the main culprit of causing this. So I'm just explaining this part, the system by system, because we will discuss further at what point as an anesthesiologist we can we can blunt this response with the help of our drugs, or like the interventional measures which we can do. The second is the endocrine system response. So I've already told you that there is a hypothalamic, the paraventricular nucleus of hypothalamus have direct connections with anterior pituitary and the posterior pituitary as well. So once this paraventricular nucleus is activated, it will affect on a hypothalamic pituitary axis, and this lead to this is hypothalamic pituitary adrenal axis, that will affect the corticotropin releasing hormone and the ACTH and the cortisol. Then there is like hypothalamus pituitary thyroid axis, that will help increase the TSH, and we will see that what it affects in the next slide. Then there is hypothalamic pituitary growth hormone axis, gonadal axis, that will increase the testosterone, causes this changes in the hormone, and the last is the hypothalamic growth hormone axis. It also have some metabolic effects. So This is a slide which is explaining everything from the endocrine leading to the all metabolic effects as well. So surgical stress will stimulate hypothalamus, and this is the main like anterior pituitary and posterior pituitary which will be affected. So with the anterior pituitary, we all know that there is corticotropin releasing hormone, which will lead to increased ACTH, increased growth hormone, and this will stimulate directly to the zona glomerulosa of the adrenal cortex, which will release the cortisol. And like with the posterior pituitary, there is increased ADH, so body will try to conserve the water and the salt as well. So there will be like decreased water retention during this surgical stress. That's why there will be the increased aldosterone and renin angiotensin system activation as well. So that will lead to decreased renal blood flow. That's why we usually see in anesthesia like the urine output little bit drops, because there is always a decrease in GFR during under the anesthesia as well. And the other thing is like sympathetic nervous system activation will lead to the decrease insulin and increased glucagon. So usually the body develops the generalized insulin resistance during this surgical stress phase. So this is the slide which I have already let you know that this is the hypothalamic pituitary axis, which will lead to cortisol increase, and there will be increased energy production, shift energy to vital organs, fight and flight, and use inflammation. Try to use the inflammation. We will see how it does this as well. And the other is the hypothalamic pituitary growth hormone axis. So growth hormone will always increase, and this will lead to lipolysis, inhibit lipid uptake by the cells, and the insulin effect will be like there will be an increased insulin resistance, and there will be increased protein degradation, and the catabolism phase can occur if this goes unchecked. This we already have discussed. So what are the effects of hormone response? So on the cardiovascular system, it will increase the heart rate, increase the cardiac output, increase the BP, and increase the oxygen demand as well. And we have already said that with an ADH, antidiuretic hormone, so there will increase sodium and water retention, and they will always increase urine output secondary to the body is adapting for the stress response. So what are the metabolic responses? We have already had a short discussion on that as well. So there will be increased blood glucose. So there will be always a hyperglycemia. Can be an increased protein catabolism as well. If we measure the protein levels in the blood, or there is increased plasma fatty acids and increased amino acids as well. So these are the metabolic response which we don't want with the surgical stress. Interestingly, there is a like the inflammatory or like the immune system response. What is the immune response to this surgical stress? So when there is a local tissue damage, so there is always the activation of the innate immunity and the cell-mediated immunity. Innate immunity, you can clearly see on like the innate immune cells becomes activated. This is a local response. So there's always like the activation of the monocytes, which will ultimately converge into macrophages. These are the antigen presenting cells. There is always an increase in the neutrophils as well. And this all happens, these all cells actually causes the increased release of pro-inflammatory cytokines and in which the interleukin 6 is one of the most notorious one to cause all these changes of the inflammation. So as we know that we have studied in the definition that there is always a hemostatic response, so there is always the anti-inflammatory cytokines as well that are released by this cortisol, adrenaline, and non-adrenaline, and they will try to mitigate this inflammatory effect to neutralize these pro-inflammatory cytokines, in which the interleukin 6 is the most important. And with this local tissue trauma, there is always the production of acute phase reactant proteins, which are usually produced by the hepatocytes, in which normally surgeons are very interested to measure the CRP. There is CRP, there is a decrease in albumin and transferrin as well, and there is always a decrease in fibrogen degradation products as well. So these are the acute phase reactant proteins. Other thing is, like I have already told, that there is an innate immunity, and then there is like the cell-mediated immunity. So in cell-mediated immunity, mostly the helper 2 cells are activated and the helper T cells are not activated. Although the antigen presenting cells are presenting to Th1, but in surgical stress response is always the helper 2 cells, which are the cytotoxic cells. And in surgical stress response, these are more activated. So they are like labeled as that if they are more activated, so there can be increased chance of increased inflammation, increased cancer recurrence, or increase like the metastasis of the cancers as well post-operatively. So still debate going on that how they do this, but in surgical stress, there is more helper T cell activation than compared to helper T1 cell activation. And these natural killer cells, they are like some I will discuss like further what are the anesthetic effects of on these natural killer cells. But these are the cells which usually are involved in inflammation, causing the apoptosis, cell damage, and virally infected cells to remove them. So they are helping in getting to overcome this surgical stress response. So if anything like our drugs affect on this, then their mechanism of action can be impaired as well. So people usually like after the surgery are very happy to see the blood markers just to see that how the things going on but I have just made mention in this the slide as well that how long these inflammatory markers remain in the blood side. So the most important, I have already told that the pro-inflammatory is interleukin 6 and anti-inflammatory is interleukin 10. So usually people measure this interleukin 6 12 to 24 hours to see the effect of the surgical stress response, and some people like CRP usually you take how much inflammation going on like after the sterile surgery. If CRP is persistently high after 72 hours, so it appears to be like there must be underlying some infection, something like that. So CRP usually comes down after like 24 to 72 hours. WBC count, there's also increase in surgical stress. We already know that in the previous slide that all monocyte neutrophils all get increased. So there was always an interest that like how can we measure the measurement of surgical stress response. So people try to try different things how they can measure this surgical stress response. And there are a couple of monitors they were using for this. Like you can see, I marked in the red box that ANI, which is called as analgesia nociception index. Then there was nociception level, NOL. There was nociceptive response, and there was PPI, the pupillary pain index. The problem with these all parameters are that they are all affected with the heart rate, blood pressure, and everything, which you can see on the slide as well. So their specificity was very less. So people said that the research going on that these are the indicators which we cannot use to measure the surgical stress response, because the heart rate, the blood pressure can affect with other things as well. So like if the patient is inadequately muscle relaxed, he can become tachycardic, tachypneic during the surgery as well. So you can't if the monitor is like relying on the heart rate variability, so it cannot predict this surgical stress response. Some people try to use this the BIS and the entropy as well, but that is like more of a level of anesthetic depth, so that went out of favor as well, that this is affected by a couple of other things. So now there's like one of the monitors which was developed by GE, and they actually people have done a lot of studies, like almost if you search on a Google or some search engine, it will like you will literally find like almost 15-20 studies on that is called as surgical pleth index. And you can see in my slide, which I have like marked on a green box, that it usually correlates with this cortisol, epinephrine, norepinephrine, and sympathetic activity. So the people use this tool to measure the surgical stress response, and they actually measure the blood levels of this all these cytokines along with this like hormones as well, just to make sure that if it goes above, then they can have a number that the patient is having a surgical stress response. So actually this surgical pleth index uses the analyzes the photoplethysmographic amplitude and photoplethysmographic pulse interval. So it's just like a pulse ox type thing, and that help in calculating some surgical stress index, which I've shown that it correlates with this cortisol, epinephrine, norepinephrine blood levels as well. So there is a number like you want to maintain it between 20 to 50, but if it's more than 50 for like more than 3 minutes, it means that patient is having pain. So you need to and pain is indirectly relating to surgical stress. So you have to give something to make that number in between to 20 to 50, between 20 and 50. Just to remove this surgical stress response. So this is one of the only equipment available to measure the surgical pleth index, but it is still not advised by any society that is it a standard of monitoring during the surgery or it is a standard to measure the surgical stress response. But this is one of the uh, the equipment which can be used for the monitoring of surgical stress response if somebody wants to do some research or something like that, because it correlates well with cortisol epinephrine levels in the blood as well. So the last part of my the presentation I'm starting, which is important, that how we can help in modifying the surgical stress response, like an anesthesiologist, at what point we can intervene, and what are the effects of our drugs on different pathways of the surgical stress response, so that we can nullify this effect of surgical stress response and get the better post-operative outcomes of the patient. So what are the anesthetic factors? So uh, total intravenous anesthesia versus volatile anesthesia. So my first point, stress response may be differentially affected using either volatile anesthesia or propofol based total intravenous anesthesia is still controversial. So that comes there's they have done some laboratory studies that if we use this volatile anesthetic agents, they have some uh, effect on which they called as hypoxemia induced factors or hypoxia inducible factors. And these hypoxia induced factors are responsible for the patients coming with the cancer surgery or metastasis. So there is always a chance of recurrence. So they are claiming that if that it's better to use the total intravenous anesthesia or TIVA, but it's still controversial because there are studies which negate this effect as well. So it's still debatable. Uh, so the second point, propofol suppresses cortisol secretion at the level of adrenals. So this is they have done the study, if you give the propofol, one single bolus dose will also decrease the cortisol secretions in the body, and that will mitigate the metabolic and endocrine effects which we have already discussed. And if you use the propofol like in a TIVA, and if you maintain the blood plasma levels of 4 to 8 microgram per ml, then it will completely blunt the cortisol levels. So if you want, I have already said that it's not superior to inhalational anesthetics that we use TIVA, but still it has been proved that with the propofol levels of 4 to 8, there is always where all the cortisol secretion from the adrenal medulla is blunted. But the ACTH levels will remain high, either we use inhalational or the IV propofol. Etomidate fell out of favor due to this. We already know that with a single dose of etomidate, it blunts the formation of this cortisol and ACTH, and it was used in sepsis patient, there were poor outcomes. So etomidate is not routinely used nowadays as IV injection agent or in an ICU for the infusion form as well. Volatile anesthetic agents, they inhibit ACTH, cortisol, catecholamine, and growth hormone to a greater extent than IV anesthetic agents such as propofol combined with remifentanil. So I have previously mentioned that it's not mandatory to use a TIVA with a propofol and this 4 to 8 mics. So you can use volatile anesthetic agents which will inhibit the ACTH, cortisol, catecholamine, and growth hormone greater than propofol. Although the propofol was mostly used with remifentanil as a TIVA in most of the procedures as well. But I will explain that there is a controversy of this inhalation anesthetic agent with that hypoxemia inducible factors which can cause the tumor recurrence and the cancer, but still the studies are going on. Another important interesting thing is that volatile anesthetic agents have a multitude of both immunosuppressive and immune activating effects. So sevoflurane, isoflurane, halothane causes this decreased natural killer cell cytotoxicity. So it means that if we are using a lot of sevoflurane, isoflurane, halothane, it can cause like the net decreased cytotoxicity by the natural killer cell. So there will be no apoptosis, no virally infected cell removed cannot be removed from the body. There is decreased cytokine released by the sevoflurane, so mostly it's affected by the interleukin 6. There is decreased neutrophil cell number and adhesion by sevoflurane, isoflurane, halothane. Another interesting effect is that all inhalation anesthetic causes decreased platelet aggregation and also the clot stability as well. So they can have an effect. So if we are thinking that the patient isn't like there is increased bleeding or anything like that, so we can use like the propofol infusion along with the decreased use of this inhalation anesthetics. Other medications which we usually commonly use in theater are like benzodiazepine. So midazolam also causes the suppression of cortisol, but the exact mechanism is still not known how it decreases, because like in propofol we know that from adrenal medulla it causes suppression, but in midazolam we don't know as well. The other two, the interesting drugs others are like alpha-2 adrenergic agonists, which we use theater in mostly like the dexmedetomidine. They are available like in the market as clonidine and melatonin as well. These are very interesting drugs because these are mostly used, and now there is like a couple of studies which are showing that they blunt the central sympathetic response to this surgical stress. And these drugs, if given like during the before putting the getting the surgeon start operation, like if putting the incision before incision, they usually help in reducing this levels of ACTH, cortisol, growth hormone as well. So dexmedetomidine is like a quite a wonderful drug to blunt the systemic surgical stress response and keeping the body at a physiology on which like there will be much less damage internally to the body, and there's a more chance of healing, like early recovery as compared to the other drugs. Opioids, very interesting because like most of the RAS protocols usually say that we should like people are moving towards like, opioid free anesthesia, but like on an opioid, systemic opioid reduces ACTH and growth hormone secretion, but by reduced secretion of corticotropin releasing hormone released at the hypothalamic level. And so it's written in the literature as well, and it's proven, I think so, in the laboratory or the volunteers, like if you give like 50 microgram per kg of this fentanyl, so it completely abolishes this all hormonal effects with surgical stress response, but at the cost of respiratory depression, post-operative nausea and vomiting, ileus. So still it's like in an RAS protocol, due to the side effects of the opiates, people usually want to avoid these drugs. They want the other drugs to be effective, like they won't get or anything, or we will discuss further that as well. But they usually want that opioid need to be used very cautiously. But these are the drugs which are still used, and these are the most potent drugs for the pain control, the systemic opioid, and they blunt the surgical stress response very well by reducing these hormonal levels as well. So these opioids also causes some immunomodulatory and the immunomodulatory effects as well. So it's proven in the literature that morphine, fentanyl, remifentanil, methadone, and codeine all causes the decrease in like the innate immunity response. They will have a less effect on the monocyte, macrophages, neutrophils as well, and whereas the oxycodone, tramadol, and hydrocodone and buprenorphine do not have any effect on the immune system. So if we are suspecting some immunosuppression or anything like that, so we can avoid the morphine or fentanyl for the patient, and we can just go for tramadol or hydrocodone. But still, like these are, I told you that these all data is coming from some laboratory animal studies and healthy volunteers, not on the patients, which we usually deal with like a lot of comorbids in the theater. There's an interesting effect that there is a like with the opioid use, there is a chance of tumor growth and cancer metastasis, and this comes from a studies on a lung cancer with small cell lung carcinomas, on which there are like mu opioid receptors, and if we use morphine for them during the surgery for the resection, there's increased overexpression of the receptors, and there can be increased chances of cancer regrowth and the metastasis as well. So it's interesting to know that the morphine has this effect. So only the morphine has been studied for these mu receptors, because I tried to find that other opioids are have some effect on these tumor recurrence or anything like that. So I couldn't able to find anything from the studies. Interesting. The other is, now we have seen the inhalational, IV, intravenous, the other drugs as well, and the opioids. Now, what is the regional? What is the effect of regional anesthesia on surgical stress response? So, neuroaxial, epidural, and spinal anesthesia block the hypothalamic pituitary axis response by blocking the efferent activation of the hypothalamus and efferent stimulation of the liver, adrenal, and pancreas. So, it's clearly written in the literature that epidural and spinal actually helps a lot in mitigating this surgical stress response. And it's the hypothalamic pituitary axis which was activated through this hypothalamus. So if we block the efferents, which like synapse on the dorsal horn of the spinal cord, so from that we don't get any efferent signals to the hypothalamus or the paraventricular nucleus. So this axis will be blocked; they will not activate. So these are the excellent modalities which can blunt this hypothalamic pituitary axis, the epidural and spinal anesthesia. And by far the most important regional technique is like thoracic epidurals. I am working here. People still here use thoracic epidurals because they want to blunt the surgical stress response. They usually put, like, if the patient is having the transverse incision, not a like the vertical incision usually we do in laparotomy. If the like they have doing the hysterectomy or something like that, they usually put the spinal anesthesia first and then they give the general anesthesia because they want to prevent the surgical stress response. I was surprised to see that they initially do this spinal and then they do the general, because in Pakistan we do not use, like for hysterectomies or something like that, the spinal anesthesia first and then the general anesthesia. We usually do the general anesthetic with the opioids, but here this is one of their protocols. They put this spinal with some opioid like diamorphine or something like that, and then after that they give the general anesthetics. Uh, Thoracic epidural anesthesia, and like it's quite written in the literature with this like abdominal aortic aneurysm surgeries. So it's if combined with general anesthetic, so there is a almost a complete reduction of the cortisol growth hormone post-operatively. There is reduced level of interleukin 6 and all the cytokines as well. So this helps in blunting the surgical stress response. But we know that with thoracic epidural there are problem and conflicting literature with this, the difficult insertion and the handling due to the post-operative hypotension as well. So but regional techniques are definitely are much more superior than the general anesthesia, including the return of gut function, reduced incidence of embolism, as well as the inflammatory response. So as we know that we are more interested in inflammatory response, so regional techniques are much better than general anesthetic technique combined with opioids, because in opioid we need to give with the opioid with the general side we need to give a very high dose of opioid to mitigate this effect of this inflammatory response. Now we go to the surgical approach. So what's the surgical approach having an effect on stress response? So we all know that laparoscopic versus open surgery. So laparoscopic surgery usually have a very favorable outcomes in response to the surgical stress response, because it will reduce the level of there will be less pain. There will be like early recovery of the gut function, early recovery of the patients as well, less tissue trauma. Uh, in the systematic review, they actually review all the surgeries, and they were of opinion that as well that laparoscopic surgery is just superior than the open surgery in comparison to surgical stress response. So wherever possible, try to get the laparoscopic approach as compared to the open approach for any surgical procedure. And they actually compared this laparoscopic surgery versus robotic surgery versus the open surgery as well. So there was no difference in the surgical stress response measurement afterwards with cortisol, epinephrine, and all these interleukins as well. As so laparoscopic and robotic surgery was the same as compared to the open surgery. So clearly the data says that the laparoscopic surgery is superior, but there are some studies which show that like in a laparoscopic surgery, this oxidative stress response, which they measure with some protein catabolism, is almost the same as an open. So they are not superior, but we can clearly, but these studies are of a very low quality. It has been explained in the literature. So still, laparoscopic surgery is the most favorable for the surgical stress response, to blunt the surgical stress response. These are a couple of studies which I mentioned. It's like a Cochrane as well, and there are on the laparoscopic surgery versus open in hepatic resections as well. So they clearly shows that the laparoscopic surgery are far superior as compared to open surgery in preventing this surgical stress response. Now, what is the effect of thermoregulation? So we all know that people undergoing anesthesia get the hypothermia due to different like conduction, convection, radiation, evaporation as well. So if the patient is hypothermic, he will trigger this stress response with the activation of hypothalamic pituitary adrenal axis and pituitary axis as well. So, and it always lead to the poor outcomes of the patient with increased oxygen requirement post-operatively, impaired wound healing, coagulopathy as well. So, as an anesthetist, we try to maintain the thermoregulation in the theater just to get better post-operative outcomes for the patient. Nutrition. So, if like the patient is already having an endogenous stressor, which I explained early in the beginning, that if patient is already having a malnutrition and the patient's nutritional status is not very well before the surgery, so this surgical stress response will affect the body more as a catabolically, and the patient body will not be in a will not respond in a normal healthy patient with no uh, like any nutritional deficiency or anything like that. So prolonged perioperative starvation times and the presence of pre-existing malnutrition increases the risk of post-operative complication and poor outcome. There are like a couple of societies who recommend that if the patient is having a surgery and mostly there are iron deficiency anemia, so they usually give this IV iron before the surgery as well, after discussion with the surgeons as well. But if it's like an urgent surgery, like a tumor metastasis surgery, so then they need to do operate fast. But if like there's some elective surgery, anything like that, they need to build up this hemoglobin or like the iron deficiency anemia as well, just to get the good post-operative outcomes as well. That's why in ARAS it's like minimization of starvation time, minimize this NPO time, uh, perioperative the preoperative carbohydrate loading as well, early return to enteral feeding post-operatively, do not put NGs. It's written in ARAS as well. So uh, if we do not use the opioids, that will prevent the ILS, so that can help in getting the early enteral nutrition as well. And adequate perioperative nutritional support and supplementation, like if preoperatively patient is deficient, so we can give something, and like post-operatively we can plan accordingly with the nutrition people, just to make the patient outcomes much more favorable. What are the hemodynamics and oxygen delivery? Uh, we know that in a surgical stress, we said that the initial response is the nervous system, which will cause this increased sympathetic activation, leading to tachycardia, which will lead to increased systemic vascular resistance, which will lead to increased blood pressures as well. On the other hand, we will be having the increased ADH that will increase the fluid and water retention. So, and with the inflammation, there will be an increased capillary permeability as well. So all these things will lead to like the patient will be like can be hypovolemic, can be having the edema as well, like hypervolemic as well. So it always causes these and we know that like we don't have any single parameter which will guide us that it's like giving this the optimization. So there are like couple of people who measure this cardiac output monitors during the intraoperatively as well. If non-invasive cardiac output available in cardiopulmonary bypass or something like that, they just want to get this idea that how they can optimize this oxygen delivery to the level of the tissues. And like global perfusion markers, we can use the lactate as well, or mixed venous oxygen saturation, just to see that how oxygen delivery going on. And most of the society people also recommend that keeping the hemoglobin around like 7 to 9, just to keep the oxygen delivery optimized in major bowel surgeries or like major cancer surgeries, just to make the optimized oxygen delivery. Because if we will be not giving the optimized oxygen delivery, there will be fluid overload and there is electrolyte disturbances with this. They will impair the post-operative outcome of the patient, because in their intraoperatively we will have to be very judicious in using the balanced crystalloid solutions, and when to use the blood as well, and are we providing the optimal oxygen delivery at the level of tissues. This is the question we need to answer during intraoperatively. So, what are the effect of glucocorticoids on the surgical stress response? So, it's a lot of literature on it. Like people are giving now to get the anti-inflammatory effect with the help of these glucocorticoids. So this is one of the systematic review and meta-analysis which uses this dexamethasone, high dose of dexamethasone, like 0.1 milligram per kg, for this hip arthroplasty and total knee arthroplasty. And they say that there is a favorable outcome without any adverse events. But still, high quality studies, I think so, will be needed just to make them. But very much literature is going on in that. People are using glucocorticoids for, because with this like dexamethasone usually people give for antibiotic, the post-operative nausea, vomiting as an analgesics as well. So people are using like high dose now just to get this anti-inflammatory effect. This is one of the trial which is still going on. This is one improve shows that improved post-operative outcome after mandibular surgeries. This is like the hepatic dissection surgeries in which they use the high dose methylpred as well. So this actually helps in like a high dose methylprednisolone, like 15 to 30 milligram per kg, blunts the inflammatory response. This has been used in cardiopulmonary bypass, but the risk versus benefit, we need to see that what is causing, what is the problem it is causing in diabetic patients, or like what are the side effects after the surgery. Like either there is like increased wound infection, increased immunosuppression. So still not advisable by most of the societies, but still people are doing a very high quality RCTs on that, giving high dose of methylprednisolone with a very selected cohort of patients and keep getting their outcomes, like and see, I think so, like in a couple of years that can become a standard practice in some of the surgeries as well. uh, Beta blockers, are the beta blockers can be used to blunt the surgical stress response. So perioperative beta blockers blunt sympathetic activity and thereby diminishes the neuroendocrine response that initially start with hypertension, tachycardia, increased cardiac output, and everything like systemic vascular resistance. And we all know that people usually use to give this perioperative beta blocker was continued that it has a mortality benefit. And but still, if we are using only beta blockade for surgical blunt the surgical stimulus, so that can cause this hypotension, post-operative hypotension and stroke as well. And this was the like the perioperative POISE 3 trial, which gave the answer in like I think so it's published in May in 2023 as well. After POISE 1, POISE 2, POISE 3. So in POISE 3 it's clearly written that like what are the map we will be targeting. So uh, if we are they like it between 16 and 80 makes no difference in the outcomes of the patients. And the other thing they were like they have written in the results as well, like uh, continuing the like the antihypertensive medications just to control the bed hypertension intraoperatively, it all depends upon the patient. And like discontinuing them before the surgery, it all depends upon the individual institutional practice and the patient condition as well. So it's not mandatory to continue the chronic antihypertensive medication to control the hypertension intraoperatively, because we don't know what is the level of surgical trauma that patient will cause this all the sympathetic and all the responses as well. So the last slide, the what are the clinical evidence of stress modulation of cognition. So if we do not blunt this hypothalamic pituitary axis, adrenal axis, and this the hypothalamus, so this high level of cortisol, which is like due to the surgical stress response, causes the modulate the functional status of the hippocampus, and this causes an profound inhibitory effect on the hippocampal cell activity. And the people who usually have a raised surgical stress response, this always causes this the more surgical stress response will be causing the more post-operative cognitive dysfunction, because in hippocampus there are like there are two receptors which are glucocorticoid and mineralocorticoid, and increased glucocorticoid receptors with the cortisol causes this post-operative cognitive dysfunction. And the other thing is that like this chronic activation of hypothalamic pituitary adrenal axis by like age and fertility also causes these problems as well, because in these old age patients the response is not like the pulse like they don't have a negative feedback effect of this cortisol as well like we have. The other thing is like they lost that circadian rhythm, they already have a high cortisol levels as well. So that's why like the old age people have mostly have the post-operative cognitive dysfunction, because with the surgical stress they have all increased cortisol, and this hippocampal activity is inhibited and lead to the problem as well. So how we can help? This is only the diagram which I have just posted, that this is all the red ones are like protein these are the effects of this surgical stress, and this is the yellow points which we can help in, like regional anesthesia. I've already told you, you have seen in your practice as well, like regional anesthesia, the patient have a good outcome, although the literature said that there is no post-operative morbidity and mortality difference, but clearly they have a better plan to the surgical stress response. Anesthetic drugs, Tiva, propofol, opioids, I have already discussed. Fluid hypervolemia, hypovolemia, hypoxia, anemia, any preconditioning cardiac problem, any as well. So that can affect me as well. So preoperative optimization, reduce the metabolic derangements. Already, if patient having an infection, we can control medication adherence or anything like that. We can just continue with that. Metabolic functions, like we need to maintain the normoglycemia, try to impair this protein catabolism as well, and the fluid balance, no hypovolemia, no hypervolemia. Although we know that we don't have any single parameter which we can use to guide our fluid management, but it's all individual patient based management. Maintenance of gastrointestinal function, aim to reduce the stress and inflammation of the alimentary tract with uh, low decrease the dose of opioids, try to not to put an NG, try to enter nutrition as quickly as possible as well. And with cognition, I already told that try to decrease this surgical stress response so that the post-operative cognitive dysfunction can we don't face this problem of post-operative cognitive dysfunction. Thank you. Any questions, I will be happy to answer. Hello, can you people hear me?
Yes, we can hear you. Any questions from the participants? We are open for the questions. There is one question by Dr. Latif Shah, Sohaib. A hypothyroid patient admitted in ICU should get thyroxine or not?
Yes, if the patient is hypothyroid, you will give the thyroxine because the metabolic effects of the thyroxine, we need to get that going on. And it's also recommended that if patient is going for a surgery and his patient is on thyroxine, you can give him or her the usual dose of thyroxine on the day of surgery.
Okay. Any other questions? I think everything is very clear because this was such an extensive research you have done on such an important topic. We have just received another question, which
Yes,
is by Rahmanullah Jan. Is routine
yes.
use of beta blocker recommended during cardiac surgery cases?
Actually, there was a POISE 1 trial which showed that if the patient is using beta blocker, this have a protective effect on the post-operative outcomes. Then there was POISE 2 trial that they have stopped, and they said that AC inhibitor, they compare different antihypertensive. Now in POISE 3, they have said that it's not mandatory to continue this chronic antihypertensive medication intraoperatively, or you can or using the new drugs to control the hypertension intraoperatively. It depends upon the patients as well. So clearly, the recommendation by American College of Cardiology was, if the patient is taking beta blockers, continue that intraoperatively. That will help in reducing the perioperative morbidity and mortality. But now the POISE 3 trial again raises the question that either we should, like, they didn't answer that the chronic antihypertensive medication, which medication? Because we are just facing, like in UK, it's like they usually institutional practice. They usually stop these AC inhibitors or ARBs 24 hours before the surgery, and beta blocker and calcium channel blockers are usually continued intraoperatively as well, like perioperatively. So according to ACC guideline, you should continue beta blocker if the patient is already taking. But if the patient is coming for surgery and you think that we can block with this beta blocker the surgical stress response, that is not mandatory.
Okay, so there is another question by Abdul Rahman that, as you have mentioned, initially spinal is given, then general anesthesia at your center where you can currently working. Does it blunt the response more or less than general anesthesia with opioids? And this is followed by another question by Hafizullah, which was actually related to the previous one, that intubation response, especially in cardiac surgery, what is the best with less complications?
So it all depends. It like here it's usual practice that if the patient is not getting the laparotomy incision, like the midline incision, if the patient is getting the transverse incision, just like for a lower below umbilical surgeries, so they usually give this spinal anesthesia with diamorphine that will help in preventing the surgical stress response. And for the intubation, they usually use the very rapid acting the L-fentanyl that have only for just to blunt the intubation response. So I have seen the patient that like after this giving the spinal and this alfentanil intubation, the patient usually like the because we don't have any measures to get this the surgical stress response, but like the hemodynamically patient remain much more stable. And it was surprised for me because putting the spinal and then giving the GA was like not routinely practiced in Pakistan as well, like in Aga Khan as well. But here it's usually the practice that people do, and it's not mandatory. Like they have the very good opioids, analgesics, and everything, so they usually do this as well for the patients. So, but it all depends upon the institutional availability. But in Pakistan, we don't have like opioids much of the time. So putting the spinal in and just to blunt the intubation response, we can use different things like we can use lignocaine as well. We can use fentanyl as well. Just to blunt the intubation response and then get the tube in, and this will help in like mitigating the hemodynamic response with this. I think so. Hafizullah was saying that. So it all depends on what drugs you have. Like if you have, they have this fentanyl, they have remifentanil, they have alfentanil available here as well, and they usually we usually to blunt the intubation response. We usually these use these very short acting opioids, and they are very helpful. That patient's heart rate don't usually go very above like 100 120, and that is the reason like with the heart patient the heart rate is the only factor which increases your oxygen demand. So we can use like if you want to blunt that response with this opioids or with you can blunt with the beta blocker as well. Very short acting like metoprolol or you can give atenolol IV as well. It depends all upon that how the like the drug armamentarium you have in your hand to control this response.
So, Sohaib, is this also answering the question by Tayyib Tahir that labetalol is used for intraoperative hypertension? Your opinion regarding the use of this beta blocker? I think this also answers the same question as you have just mentioned.
Yeah, labetalol, like if it all depends on which drug you have. If you have this labetalol, if you have to give a very like very frequently to control the blood pressure something, then you can use this infusion as well. Or like we usually, and it all depends upon what the problem is. Like we use hydroxyzine, GTN, depending upon the patient's comorbid and condition. If the patient is having like if you have a laparoscopic surgery, we know that with the intra-abdominal insufflation of this gas, it always increases the afterload, and you want something that which can causes this arterial or vasodilator. So people usually use the hydroxyzine, not the or GTN. They will not use any beta blocker or anything like that. So it all depends upon the what the patient heart condition is, what the surgery going on, and what the drugs you have. If you are comfortable in using the labetalol infusion, you can just like start labetalol infusion as well. We don't have in Pakistan the IV atenolol in theater, but here we have atenolol, so people here mostly use atenolol. But I trained in Pakistan, so I usually use the metoprolol. So it all depends upon in which drug you are comfortable and what you are doing with that drug. So it all depends on that.
So there is one last question. We are just about time because you started late.
Sorry.
So we are giving participants to ask more questions. So Rahman Ullah Jan has asked, as you said earlier, that opioids during cardiopulmonary bypass response are good. I don't understand this. I would request Rahmanullah Jan to unmute himself and direct ask the question. So he's further saying, so should we stop opioid after
Yeah.
coronary bypass and
Actually,
use another
yeah.
analgesic for pain control?
Asma, there was a slide actually. I put it on, and there was a like statement from me as well that if we give a high dose opioid just before going to the cardiopulmonary bypass, so these are good. And after that, we should stop opioid after cardiopulmonary bypass. So uh, the answer to this question is that the people have used two things, because this cardiopulmonary bypass is one of the most intense systematic inflammatory response which we trigger in the body during this cardiac surgery. So people have used two things: one, the very high dose opioids, and the other is they have done the high dose steroids as well, methylprednisolone. And still, people say that the opioid anesthetic versus the inhalational or intravenous anesthetic during the cardiopulmonary bypass are not superior. So, but opioids blunts more the ACTH, cortisol, and the growth hormone as compared to volatile anesthetic during the cardiopulmonary bypass. So then there was a like people started using this high dose methylpred with the just to blunt this inflammatory response and get the good post-operative outcome. Still, it's not a part of practice in most of the societies. But people are using this high dose steroids to blunt this cardiopulmonary bypass response and the opioids as well. But it's not like we should stop opioid after cardiopulmonary bypass. But if, like dexmedetomidine, I told you that people are using more of these non-opioid based drugs just to get out of the side effects of these opioids, like sedation, ileus, respiratory depression. So they don't want to use that. So but if the patient needed like in I already mentioned in my statement as well, that opioids are the main first line of drugs to control the pain and nociception. So that's why we are relying on these opioids. We can't stop it completely, but if we are getting a side effects of this respiratory depression, sedation, ileus, then we need to think otherwise, that we need to modify our treatment plan.
Thank you so much, Dr. Sohaib. Any more questions? I think no more questions. So I'm really grateful to you for giving us such an insight on this topic with such a diverse evidence and with evidence-based topic. So I would request Dr. Akhtar Wahid Khan first to kindly give us the feedback. And then I would, in the end, I would request Dr. Shabir Jumani to have few words with us.
You, how do I give that? It was a very nice presentation. Can you hear me, Dr. Saab?
Yes,
Yes,
we can
sir.
hear you.
Yes, sir. Yes, sir.
Oh, it was a very nice presentation, but so exhaustive. You know, you have to remember a lot of things. I still remember. I've not forgotten. Now, let me ask you one question.
Yes.
I have been to Kilmarnock. I have been to Glasgow. I have been to Edinburgh. Which place you are? Let me ask you this thing first.
Sir, I am in Dumfries.
Every, I
Yes.
see. I think, are you still using their Omnipar and Pepiveratum or something like that in pre-medication?
No, sir. No, sir. They are not using it.
No more, right? It was in my time. I was in late 60s.
Okay,
Late
sir.
60s. I was there, I see. Very, very good presentation. But I was really impressed me with your presentation. A lot of things, of course, I must say,
Thank you, sir.
changes are there.
Thank you, sir.
Last but not the least, Dr. Shabir, if you are here, kindly please have a few words with us.
The presenter was Dr. Sohaib. You know, so needless to say that the presentation was excellent. You know, particularly I was impressed with his answers to the questions. You know, they were to the point and very concise. You know, and comprehensive. Thank you very much, Dr. Sohaib, for delivering such a nice lecture.
Thank you, sir.
Thank you so
Thanks.
much, Sohaib, and thank you, Dr. Akhtar. Sir, would you were saying something, please?
Thank you.
Thank you. So thank you so much, Sohaib, and I would request everyone who is present right now to kindly fill in the feedback form so that you can get the e-certificate. We have been receiving a few complaints regarding not receiving of the e-certificate. So actually, it was initially shared that the e-certificate is usually given to only those who have attended a certain time of the presentation or the talk or the lecture, and also filled in the feedback form. So this is the basic minimum requirement which we need from all of you to kindly fill in the feedback form in order to get the certificate. I'm really thankful to you. Your feedbacks are always appreciated. And thank you for your time and joining us. Thank you, Dr. Sohaib, and thank you all. Have a good night.
Thank you, Usman. Thank you.
Thank you.